Welcome to AETCM, the emergency medicine channel. Today let us discuss about dyspnea, orthopnea, PND. Dyspnea means breathlessness. Orthopnea means when the patient is lying down, he is getting breathlessness. PND means paroxysmal nocturnal dyspnea. Suddenly during night time, patient is getting breathlessness. These are different grades of breathlessness. There are breathlessness can occur during lateral positions, supine position, sitting posture. There are various postures. It may be dependent on the postures also. We will see all these things. Dyspnea is defined as unpleasant subjective awareness of one's own breathing. So it is unpleasant. Normally we don't feel our breathing pattern. We don't think that we are breathing with our effort. It's a silent process. We never notice that we are breathing. But here, patient can feel that he is trying to breathe, and it is unpleasant. Very easily we can experience this. If you run for half an hour, then you can feel that you are getting palpitation, breathlessness. All depends on your capacity to exert. Some individuals may not develop breathlessness even after running 1 or 2 hours because they are trained for that. Some individuals get breathlessness even after running for 5 minutes or 10 minutes. That is because they are trained. But there are some clinical conditions like cardiac failure, lung failure, anemia. All these things patient develops breathlessness very fast. So that is an unpleasant subjective awareness of sensation of breathing. Some conditions you can get breathlessness due to LV failure, due to myocardial infarction. But this myocardial infarction will be silent in them because they have autonomic dysfunction like diabetes, autonomic dysfunction, nerve damage to heart. Nerves are damaged which supplies the heart. So they don't experience the pain of myocardial infarction or ischemic heart disease, but they experience the breathlessness. This is called as angina equivalent. So anybody who is having a heart attack, after heart attack, if they are not feeling pain because of diabetic neuropathy, then if they develop breathlessness, that is a symptom which is equivalent to angina. So this is called as anginal equivalent. Chronic dyspnea always indicates left ventricular failure. Lung diseases are a separate entity. Lung diseases like COPD, ILD, bronchiectasis, all these conditions can produce breathlessness. But in heart disease, chronic dyspnea always indicates a condition that is left ventricular failure. Right ventricular failure as such will not produce any breathlessness. That produces peripheral edema, ascites, hepatomegaly, splenomegaly, like that. But left ventricular failure will produce pulmonary edema and breathlessness. And there are several acute cardiac conditions can produce acute pulmonary edema. Like somebody is having normal heart, suddenly they develop severe tachycardia, supraventricular tachycardia, atrial fibrillation. Suddenly left ventricle may go to failure. That produces acute breathlessness. So like that, acute breathlessness also can be due to left ventricular failure, but the causes are different in that condition and causes are different in chronic LV failure. Now there is a condition. There is a condition called as paroxysmal nocturnal dyspnea. So any patient who is having a failing heart, not completely failed, an impending failure or a mild cardiac failure. Normally, when the patient is standing up and walking, the circulation will be taken care by the walking or standing up. More blood can be pulled to the peripheries, and from there it may go to extravascular compartment. But when the patient is lying down, you can see all the blood or fluid in the peripheral circulation or fluid in the extravascular compartment may shift to intravascular compartment during night time. And that increasing fluid in the intravascular compartment can go to right ventricle, then left ventricle, if the left ventricle has got a failure, even if it is minimal, night time suddenly patient can develop breathlessness. This is called as paroxysmal nocturnal dyspnea. So patient will be lying down for a long time, like 8 o'clock patient has started sleeping. Around 1 o'clock or 2 o'clock, suddenly patient gets up for breath, breathing difficulty, and he may sit for half an hour, 1 hour. Then he may even walk in the room. He may go near the windows to get fresh air. Then after that it get relieved and patient may come back to the bed. So this is called as paroxysmal nocturnal dyspnea. This is due to the shift of fluid from the extravascular compartment to the intravascular compartment. That means to the veins. From vein it will go to the right ventricle. From there it will try to go to left ventricle, but left ventricle is already failed. It is not able to accommodate more fluid. So the fluid will remain in the lungs, in the pulmonary circulation, and patient develops breathlessness due to pulmonary edema in the night. This is called as paroxysmal nocturnal dyspnea. So this is one of the earliest phase of cardiac failure. That may progress, then patient develops orthopnea. So here you can see patient is lying down, reabsorption of fluid from the tissues into the blood compartment, the intravascular compartment, that will go to the heart to right ventricle. From there it will try to reach the left ventricle. Left ventricle is not able to take up this more fluid, so the fluid will accumulate in the lung circulation. Pulmonary edema develops. Patient sits up, stand up, go to the window for fresh air. After some times the fluid will settle. It will again go back to the extravascular compartment. The breathlessness decreases. Patient can again lie down. So when you are auscultating this patient, night time you can get crepitations, wheeze, saturation can be low. All these things are typical for cardiac failure. Now that orthopnea we have discussed, what that was the earliest phase of cardiac failure, but afterwards the left ventricle failure may increase. So it will not be able to, the left ventricle will not be able to take up any extra fluid. So immediately after lying down itself, patient develops breathlessness. This is called as orthopnea. Patient is unable to lie down. So you can see many patients who is having cardiac failure, they will not be able to lie down straight. They will try to sit up and sleep. Okay, in a propped up position only they will be able to sleep. This is called as orthopnea. So here fluid accumulates in the air spaces. That fluid prevents the oxygenation in the lungs. This is orthopnea. So there are various mechanisms for breathlessness in the night time. It can be due to the fluid. We have already seen that fluid shifting from the extravascular compartment to intravascular compartment. That is one mechanism. Second thing, during night time when you are lying down, your diaphragm may go up. So that reduces the lung capacity. That is a second important mechanism. Third mechanism is when we are lying down, our posterior part of the lung, that is posterior part of the lung, movement is normally like this. That will not move. What we have to understand is our predominant lung part is in the posterior area. If you know the surface marking of lung, you can understand that anterior chest has got upper lobes and posterior chest predominantly it is the lower lobes. So the movement of lower lobe is completely reduced because of the bed which prevents the expansion of the posterior lobe. So the movement is completely reduced. So that part also not reduced. Diaphragm is pushed up. So two things, total lung area is reduced, and on top of that this fluid will accumulate, like pulmonary edema occurs, left ventricle is failed. So all these mechanisms will reduce the lung compliance and patient develops breathlessness. And during night time around 2 o'clock, 3 o'clock, there will be adrenergic surge in our body. Patient will develop some adrenergic activities like tachycardia, all these things. So that time also patient can develop some breathlessness. So these are the mechanism for breathlessness in the night time. But in COPD, other condition, asthma, also you can get breathlessness. There the mechanism is slightly different. So early morning hours there will be a dip in the steroid level, then there is a surge of the steroid after some time. So during that dip, patient who is having asthma, they can develop bronchoconstriction and they can develop breathlessness. That's why breathlessness in asthma also during night time predominantly. In COPD the mechanism is slightly different. When the patient is having chronic bronchitis, they normally during daytime they try to spit off the sputum. But during the night time, the sputum will accumulate in the bronchus and the alveoli. So they are not trying to spitting it out. So that can accumulate in the night time. Then they can develop breathlessness. So various mechanisms are postulated. But in cardiac failure, it is always due to the extravascular compartment. From extravascular compartment, fluid will come to the venous compartment, that will go to the RV. From there it will try to enter to the LV. Between lungs are there, the LV is failed, so that fluid will accumulate in the lungs and produces pulmonary edema. So here you can see the various mechanisms, redistribution of fluid to the venous compartments that takes the fluid to the lungs. There it is blocked, patient develops pulmonary edema. And that edema itself can produce due to various other mechanisms also. During early hours, patient can develop hypoxemia. So already fluid is filled in the alveoli, that produces some bronchoconstriction, and during early hours there is a dip in the steroid levels and there is a surge in the steroid level after some time. So during that dip, acute dip, there will be bronchoconstriction that contributes to breathlessness. If the patient becomes normal, after that there is a surge in the adrenergic mechanism, so there is a tachycardia and cardiac failure can aggravate. So during that time also patient can develop breathlessness. There are a lot of other theories which is also present in the mechanism of breathlessness due to cardiac failure, but all these theories we will not be able to correlate with the patient's symptoms many a times. But the most convincing mechanism is always fluid shift from the extravascular compartment to the intravascular compartment. Now there is a classification for dyspnea, that is NYHA classification, New York Heart Association classification. This classification is there for angina, palpitation, dyspnea, all cardiac symptoms. You can use this classification. So in simple words you can explain this. Class 1 means unaccustomed work produces symptoms. Class 2 means an accustomed work can produce symptoms. Class 3, daily routine activities can produce symptoms. Class 4, symptoms even at rest. For example, a person is walking every day morning, he is walking for 1 kilometer. Okay, so one day he is walking for 1.5 kilometers. So during that 1.5 kilometers, like every day he was walking for 1 kilometer, he never had breathlessness. So today he walked for 1.5 kilometers, he developed breathlessness. That is class 1. Unaccustomed work produces symptoms. He never walked for 1.5 kilometers in his life. Suddenly he is walking for 1.5 kilometers, he is getting breathlessness. So that is class 1. Class 2 means the same person every day is walking for 1 kilometer. Now during that 1 kilometer, today he is getting breathlessness. So it is class 2 dyspnea or NYHA class 2. So the same thing is applicable for angina also. So if the patient develops angina during that 1 kilometer, it is class 2 angina. Now class 3 means daily routine activities precipitate the symptom. That means from bed he is getting up, he is going to bathroom, he is doing his daily routine activities, combing his hair, taking a shirt or pant, wearing that. During that time he is getting breathlessness, then it is class 3 NYHA breathlessness. Class 4 means at rest. So patient normally when the patient gets breathlessness, he try to take rest and the breathlessness will be relieved. But here during rest also patient develops breathlessness, that is class 4. For example, somebody is having severe cardiac failure, fluid overloaded condition. He is having breathlessness on walking, he is having breathlessness on daily routine activities, but he is getting breathlessness even on lying down, even on propped up position, he is getting breathlessness, means he is fully fluid overloaded. We have to remove some fluid, then only his symptoms will be relieved. So that is class 4. Now there is another classification, MRC classification, Medical Research Council, that is almost similar to that, but this has created a lot of confusion with NYHA classification. So you can use one of these classification, either MRC or NYHA. Both are almost similar. Here there are 5 classes, there only 4 classes are there. That is easy to remember, but this classification is mainly used for respiratory condition. That classification, NYHA classification, is mainly used for cardiac condition, but all practical purposes we can use NYHA classification. That is easy to remember and easy to use. This is also very good classification, but many doctors, they find it difficult to remember this classification. Whatever it is, you can use this or that, depending on your capacity, you can use this. Now there is another condition which is platypnea or orthodeoxia. So this is slightly different from previous mechanism. Here patient develops breathlessness on standing posture or sitting posture, that will be relieved by lying down posture. The classical example for this is hepatopulmonary syndrome, that produces many shunts, arteriovenous shunts. This is the classical example for that, but the other conditions like venous to arterial shunting, intracardiac shunting, ARDS, so many other things also explained. But orthodeoxia or platypnea is a classical finding seen in hepatopulmonary syndrome, that is due to the shunt formation inside the lungs. So this is a terminal event in the patients who is having chronic liver disease. Trepopnea means patient develops breathlessness on one side, like patient is having a problem on the right sided lung. That means patient is having bronchiectasis on one side. So if the patient is lying down on that side, there will be accumulation of sputum on that area and it can produce breathlessness. If there is a lesion on the right side, if the patient is lying down on the left side and the free movement of the left side is reduced, then also you can get breathlessness. So many conditions produces breathlessness on right side, left side, supine posture, like that you can get. In theory you can tell all these things, but some patients will have difficulty when they are lying down on the opposite side of the lung disease, like if there is a malignancy on the ribs of right side. If the patient is lying down on the left side, the right side movement will be more, that creates more pain. So patient will try to sleep on the right side, because lesion is on the right side. If the patient is lying down on the right side, that movement of that side will be reduced and patient will be more comfortable. So that all depends on patient perception on pain and other symptoms. So but there is a condition called as trepopnea, that in that condition patient will develop breathlessness on that side. So another important problem in breathlessness is we have to always ask when the breathlessness started, whether you are trying to climb a stair, whether you try to walk for 1 kilometer, or without any provocation suddenly patient develops breathlessness, like flash pulmonary edema. Somebody is having flash pulmonary edema due to renal failure, or tachyarrhythmias producing left ventricular failure induced pulmonary edema, or pulmonary embolism producing breathlessness, or aspiration of some material, especially in children, produces breathlessness. So the time of onset and progression is very, very important in patients who is having history of dyspnea. Like somebody is having a progressive pleural effusion. So they tell that for 1 or 2 weeks he is feeling slight breathlessness. Now suddenly it is increased. That means it's a progressive disease. Or somebody is having a progressive breathlessness over months. That can be due to ILD. Or suddenly patient develops breathlessness after an episode of chest pain. That can be due to post myocardial infarction, left ventricular failure. somebody is having a prolonged travel and suddenly there is a swelling in the right lower leg, that after 1 or 2 days patient is developing breathlessness. That can be due to DVT and pulmonary embolism. Like that, history of onset and progression is very, very important. Now, aggravating relieving factors also very important. Associated symptoms also very important. Aggravating relieving factor, like patient develops breathlessness after exposure to dust, or after taking alcohol, or after prolonged travel, or patient is after lying down for a long time, patient is developing breathlessness. All these things are important. Now, pleuritic chest pain may indicate pneumonia or pulmonary embolism. Past history of malignancy can indicate rib involvement, fractures. Other history is also very, very important. Past history of smoking, past history of dust allergies, family history of dust allergy. All these things are important to know what is the mechanism of breathlessness. Now, when the patient coming with breathlessness to emergency room, we have to always see whether it is a respiratory cause or cardiac cause. In respiratory causes, mostly like asthma or COPD, history is very important. Here also history is very important, whether the patient is having chest pain, patient is having orthopnea, PND history, ECG changes, all these things are important. Another important thing is in cardiac failure, peripheries are always cold, because when there is a cardiac failure, initially there is vasoconstriction that produces peripheries are cold, whereas in COPD, carbon dioxide retention, breathlessness, this carbon dioxide produces vasodilatation in the peripheries. So one condition which can produce warm peripheries, there is always COPD with acute breathlessness. Cardiac failure also can produce warm peripheries, conditions like beriberi, like thiamine deficiency. In thiamine deficiency, you can get peripheral arteriovenous shunting, and that produces warm peripheries. So one condition which can produce warm peripheries and cardiac failure is thiamine deficiency, beriberi. But whereas in COPD, it is because of the carbon dioxide levels, high carbon dioxide levels produces vasodilatation, peripheries are warm. All other cardiac failure condition, peripheries are cold. Now, if you take an X-ray in pulmonary edema, you can see bilateral non-homogeneous opacities, whereas in asthma and COPD, the lungs will be more darker than normal. That is because of the air trapping inside the lungs. And another important investigation will be you take an ECG. In cardiac disease, ECG changes are definitely there. Lung diseases, it may not be there. Another important investigation is BNP. BNP levels are elevated in left ventricular failure, that may not be elevated in asthma or COPD. So these are the normal things you can see in patients who is having cardiac failure and lung failure. Remember, wheeze, crepitations, all are seen in both conditions. Like you take cardiac failure who is having pulmonary edema, you auscultate, bilateral basal crepitations are seen. Then if you auscultate, again you can get wheeze, that is because of the constriction of bronchus, because of the peribronchial water content. Same thing you can get in COPD also, you can get wheeze, you can get crepitations. But in lung diseases, wheeze is a predominant sign, whereas heart diseases, crepitations are predominant sign. That's all. Now, normally when the patient come to ER, we take chest X-ray to see pulmonary edema or not. BNP will be elevated in cardiac disease. ABG normally shows type 1 or type 2 respiratory failure in asthma and COPD, and there will be compensation in COPD, whereas heart disease, it will be only type 1 respiratory failure. Echo should be done in patients who is having cardiac disease. CBC can be done in patients with severe failure, because in cardiac failure, anemia is a trigger, or it can lead to anemia can trigger cardiac failure in those who are having a pre-existing heart disease, and it can produce cardiac failure also because of fluid overloaded condition. Whereas in COPD, you can get polycythemia. The counts are the RBC count is elevated. That is because of the chronic hypoxemia, erythropoietin overproduction. Patient develops polycythemia. Whereas in cardiac failure, you get either anemia or normal HP percent. Now, other infection screens should be ruled out because both in COPD and cardiac failure, it can be aggravated by infection. Like a patient who is having cardiac failure, pre-existing cardiac failure, if he develops a viral fever, the tachycardia, high degree fever, all these things can precipitate cardiac failure. So, infection screen has to be done in all patients. Now, when the patient come to emergency room, always try to keep the patient in propped up position. That is very, very important. You can see the posterior part of the lung is relieved, completely relieved. It is not restricted. The movement of posterior part of the lung is not restricted here. So, the movement can be easy. Diaphragm will be pushed down, and when you are sitting up like this, you can use your shoulders to help the breathing. So, this position is best position for the patients who is having both cardiac breathlessness and lung disease. Both in cardiac asthma and COPD or asthma, this is the best position for the patient. So, propped up position first thing. Next, you can use oxygen depending on the type of breathing difficulty. In simple asthma, you can use nasal prongs, face mask, and patient who is having severe COPD or pulmonary edema, here you go for NIV, non-invasive ventilation. In that non-invasive ventilation, we are trying to give forceful air inside the alveoli, that may be with oxygen or without oxygen. So, forcefully these collapsed alveoli will be opened. The fluid inside the alveoli, either it is secretions or due to pulmonary edema, it will be displaced and more area will be created for breathing. Okay, more and more collapsed alveoli will be recruited for breathing. More and more dead spaces will be utilized for breathing. So, this is one of the best way of treating patients who is having breathlessness, whether it is cardiac asthma or respiratory diseases. Only major contraindication may be vomiting and like low GCS. This is not indicated because patient cooperation is very, very important here. Now, management, you can use morphine in both the condition, whether it is a cardiac failure or respiratory failure. Low dose of morphine can be given, that relieves the anxiety, fear, tachycardia, everything, but we have to be very careful. More dose of morphine can produce bradycardia or respiratory distress. So, a small dose of morphine will be helpful in all types of breathlessness. Oxygen has to be given, we already discussed. Lasix can be given in both type of conditions, because when the patient come with acute breathlessness, we will have to give Lasix, because that time we may not be knowing whether it's a cardiac failure or lung disease. Give Lasix, that will be helpful in cardiac failure, it will remove fluid. Even COPD with corpulmonal, some amount of fluid removal can be helpful. But only thing, Lasix removes potassium. Potassium is very, very important for respiratory muscle activity. So, we have to be very careful. If the potassium is coming down, we have to replace it, and we have to avoid second dose of Lasix. Whereas in cardiac failure, you can give Lasix as a bolus dose. Then if the BP is slightly low, you can start it as an infusion that will not reduce the BP and removes the water. NIV we have discussed. Fluid restriction, 1 to 1.2 liter fluid restriction is required in cardiac failure, liver failure, kidney failure. Salt restriction has to be there, because salt and water can produce further fluid retention. By salt can produce further fluid retention. So, we have to be very careful. If the patient is having cardiac failure, you can use dopamine, dobutamine and noradrenaline. So, noradrenaline will be first choice, then add dobutamine, that is the second choice in cardiac failure. Then once the patient is stabilized, we can start AC inhibitors, ARBs, beta blockers to prevent the remodeling of ventricle and prevent tachycardia and reverse the cardiac failure. Nebulization should be done in patients who are having asthma or COPD. So, we have discussed about one of the major clinical problem which come to emergency room, because of various reasons. Breathlessness is one of the major problem in emergency room. It can be due to asthma, it can be due to COPD, it can be due to cardiac failure, it can be due to anemia, it can be due to arrhythmias, it can be due to pulmonary embolism, it can be due to malignancy producing rib fracture or rib involvement. So there are large number of causes which produces breathlessness, which can come to emergency room. A detailed knowledge of this differential diagnosis is very, very important to tackle this situation, and investigation is also very important, because if you don't know to read the ABG findings, you will be missing the diagnosis, and if you don't know to do the BNP levels, then you may be missing cardiac failure, because every emergency room may not have an echo probe in that area. So if a point of care BNP is there, that easily differentiate between a cardiac failure and lung failure. But some lung diseases like COPD with core pulmonary or pulmonary embolism with RV failure also can produce elevation in the BNP. So these investigations are not 100% foolproof that that will give only one diagnosis. So it can contribute to your clinical knowledge, that's all. So a proper clinical history, clinical examination, then some of these investigations like ECG, BNP, all these things will help you to make a diagnosis. But when we are treating, most of the time we treat it as a cocktail treatment. So when the patient coming with acute breathlessness, we may not be knowing whether it is a COPD or asthma or cardiac failure, because patient may be coming first time there, and patient bystanders may not be knowing what was the proper history. They may not be able to give any history at all sometimes. So we have to examine, we have to find out, we have to treat the patient with a cocktail of oxygen, BiPAP, some Lasix. Then try to analyze what is the condition, then proper treatment can be given. If the patient ultimately come to know that patient is having COPD, you'll have to immediately stop the Lasix, because Lasix can produce sometimes hypokalemia that can aggravate the problem. So all these things are very important. Thank you.